All right. Well, I'm Dr. Blake Gibson. I'm a staff child and adolescent psychiatrist in the Department of Behavioral Medicine at WVU. And I'm one of two all virtual faculty in the department. As you all are so well aware, WVU, prior to the pandemic, even really has led the way in virtual psychiatric care across our state and really done excellent work. So I'm excited to be part of that legacy of innovation. I live in Pittsburgh, so if you ever come up, you can have a real pepperoni roll. No offense meant. But it's just such a pleasure to be in the department and to be in the state of West Virginia. So today's talk is about our new virtual adolescent partial hospitalization program. And of course, I had to make it campy. Special thanks to Lauren Lasnik. You'll hear more about her. She's going to be our director for the program. So before we talk about like partial hospitalization, which is maybe a term you're not familiar with because they're not really present in West Virginia, let's talk a little bit about what some of these terms mean. And these can be called intermediate levels of care. So on one side, you have residential treatment facilities of whatever form they may take, PRTF, RTF, whatever, inpatient hospitalization psychiatrically. And then on the other hand, you have outpatient treatment, which is your typical once a month or less psychiatric appointments, once a week or less psychologist or social work or therapist or counselor appointments. So the intermediate levels of care sit in between that. Partial hospitalization is a definition that varies depending on state and payer and statute, but in general, it's a Monday to Friday thing that lasts most of the day. Sometimes it's 5 hours, sometimes it's 6 hours, but that's kind of a good ballpark. Very frequently, there is an MD attached to the program, although even at places like McLean, sometimes many times they have an APP that runs the partial program. So it's not necessarily MD led. Intensive outpatient treatment program is kind of a little bit less intensive. Typically, it's 3 days a week. In Pittsburgh, we had a Monday program, 3 days a week, 3 to 4 hours. We had an afternoon program, and then we had like a swing shift program. So, like that 4 to 7 p.m. It's a nightmare to staff those programs, right? Who wants to work from 4 to 7 p.m.? But sometimes IOPs operate that way because kids can go to school, adults can go to work, and it works out for the patients. Again, sometimes an MD runs the program, sometimes it's an APP for med management. Some IOPs have no med management at all. So you may have heard of the company called Charlie Health. I have no financial relationship, no affiliation with them at all. They were started by, I believe, a social worker from Montana, which is where I'm originally from. So I found that interesting. And they are in a bunch of states now. And they have therapists, counselors with no medication management, and they run kind of an IOP model. So, like anything in psychiatry, the term is very variable depending on state and situation, right? There's some RTFs that look very different from others, some inpatient units that look very different. It's no different in intermediate levels of care. There are sometimes themes to the intermediate level of care. So in Pittsburgh, where I trained, we had an eating disorder partial, an eating disorder IOP, IOP for people with autism or intellectual disability. So sometimes there's a certain focus of the intermediate level of care. And sometimes it's a generalist program. So if you hear me use these terms, that's sort of what I'm meaning by them. While not everyone would probably group these in intermediate levels of care, I think it's worth sort of lumping it all together. I'm a lumper and not a splitter, as you'll get to know. There's this mobile crisis service concept, and in some states it's county-based, some states it's region-based, and the idea here is a kid gets into a mental health crisis or an adult, and a specialized unit comes out to them. Obviously, those services vary in our own state in terms of their responsiveness, in terms of their quality, in terms of their availability. The wraparound model, again, sort of a CMS definition that gets variations on a theme. We call it CSET in this state. is a couple days a week for a couple hours, sometimes can include crisis, sometimes not. And there's a variety in wraparound services. In Pennsylvania, typically the wraparound services had not terminal degree folks, so kind of more bachelor's, master's, not so much the PhD level psychologists or therapists. Family-based, which is not in West Virginia, I hope I see the day that it arrives in our state, is to me like, wraparound on steroids. It's like, PhD level folks. It's like much more crisis involved and many more days in the week. So that's just sort of a primer on, intermediate levels of care to give you a little background.
There was a comment from Lauren that
Yes.
said wraparound is included in CSAID, but patients can receive WF without CSAID as well. There is a
Yes.
FFT family therapy program in West Virginia, and CSAID can be increased to daily services.
And that's such a great point. I love Dr. Swagger saying that, right? Because this is that back to that thing. Every state, every region has a wide variety on what they can do, right? In Pennsylvania, wraparound would do no more than 2 days. And if you did more than 2 days, you were going to get an email from a service coordinator saying, escalation of services is needed. We need to go to family-based. So I think in West Virginia, because we have a limited suite of services, each service sort of flexes more than other states I've seen, which is wonderful that we're trying to fill those holes. So there's a lot of partials in the United States. There's not a lot of evidence behind them. And here's what I mean by that, published evidence. So clinically, we all know this works. You would probably never find a child psychiatrist that says partial doesn't work for adolescents. We know it works. We do it every day in all these different states. But the published literature has lagged behind that. There's some meta-analysis, there's some analysis. Some of the data is actually from other countries, like in Europe. Some of the data that is published shows that partials or intermediate levels of care that use DBT have particularly good outcomes. But I don't know that that's the secret sauce. I don't want to come to this talk and say DBT is how all these partials work, because a lot of them don't do that. And a lot of them do other things too, not just dialectical behavioral therapy. A couple years ago, the Journal for the Academy of Child and Adolescent Psychiatrists put out a call saying, hey, we need researchers to publish more data on partials because we know they work and we want to show that data and we want to help insurance companies see that data to be more willing to pay for these important services. So I'll talk about this later in the talk, but the Department of Behavioral Medicine, WVU, I think we want to answer that call. I think part of this program you're going to hear about today is going to include a hefty research component to try to address these gaps in the literature. So if you're not aware, which everyone on the call probably is, in 2019, the Department of Justice sort of adjudicated a settlement with the state of West Virginia to create CSAID and address the civil rights violation that is having all these residential treatment facilities and inpatient facilities and sort of nothing in between that and outpatient, right? So the ruling in the federal court, in my summary, which I'm not a lawyer, is, that's a civil rights violation. It's not the least restrictive means of care for every kid in need of mental health services. So since CSAID has come into fruition, the Kids Thrive website, which sort of tracks and publishes data associated with the effort to address this adjudication, there's been a 27% increase in CSAID services. Over 1,900 kids have been served. And I know Dr. Swagger has even more fun stats associated with that. That's just sort of what I had at my fingertips. But it's been a really important piece at addressing we can't just send all these kids to Alabama. We can't just send these kids to residential facilities as the only option of treatment when things don't work in the outpatient setting. In West Virginia, RTF placement has become, I would say, very frequent, very commonplace, right? Hundreds of kids a month, depends on the month you look at, depends on, whether it's foster alone or not, but a lot of our kids are going out of state. A lot of our kids are going to in-state facilities. This is a very costly thing. It's been deemed a civil rights violation in some cases. This is a problem. In my estimation, we're also the last state without partial hospitalization for adolescents. Even Wyoming has agreements with Northern Colorado. Even Alaska has agreements with the University of Washington. How have we ended up the last state without this? So this is a famous meme from recent times. I had to put in something fun, right? So this is what I look like when we find a way to get the adolescent the care they need in the least restrictive way possible. So one of our solutions to chip in and assist with the work of CSED and PBS and all these other great entities is to create this partial hospitalization program. And we're going to do it virtually for a number of reasons. It turns out virtual partial is potentially more efficacious than in person. It turns out that virtual partial has better attendance than in person for adolescents. And we live in a big state, right? Stem to stern, it's like 7 hours, and Morgantown ain't in the middle. So, realizing the geographic challenges of our patients made it important that we also do this virtually. So, currently, the program will accept three different payers, Aetna, Blue Cross, and Peak. We'll take kids age 12 to 18 if they're still in school. The 12 has an asterisk on it, right? If I have a group of 17-year-olds, I'm not going to add a 12-year-old to that group. They're going to need to wait for a different cohort. But that's kind of the age range we're targeting. And we will accept nearly any diagnosis. Substance use and eating disorders need to be co-occurring. We are a generalist partial. We do not have the facilities in person to provide meals and provide after meal support, right? That is a true eating disorder partial. But we do have a wide suite of services and acumen of our staff, which I'll talk about here in a minute, so we can handle, some level of co-occurrence. Mild autism and mild intellectual disability is definitely accepted. And in my experience, kids with these conditions do really well in the partial. There's a lot of camaraderie and community and social skills component and a lot of work that can happen. I'll just always remember this little guy with autism. He was just such a cute person, right? Just so earnest and so loving. He just didn't quite understand a lot of what was going on around him. He came to like the partial so much, we had a really hard time discharging him because it was so different from his school or his life in terms of the support and the community and the understanding that he had received. Attendance is a big thing for a virtual partial, right? You gotta log on, you gotta be present. And so if you're contemplating referring somebody, please, consider, hey, are these people who have historically shown up to their appointments? Are these people who are historically engaged? Because, I talked to a kid for a whole week under a blanket once at partial. I'm willing to do that, but you gotta log in. We can't help if you don't log in. It's just that simple. An adult has to be around the kid when they do the program. So they can go to Mima's house during the day while mom works. Some schools we've talked to are willing to let kids who participate in the program do so from an empty office next to the school counselor. So because it's virtual, we can be very flexible, but an adult needs to be on hand. If a kid gets in crisis, we need mechanisms to activate for safety. And I think an important thing that I want to make clear whenever I talk about the partial is we're happy to take anyone from anywhere in West Virginia, but we don't have the bandwidth to keep them forever, right? The Department of Behavioral Medicine is just not able to see every kid in the state. So the therapists and the outpatient services that they came from, we really seek to return them to those services, assuming that's what the patient wants. We've done a lot of hard work to have money set aside for accoutrements and addressing of social justice. So if a kid doesn't have a reliable internet connection, we have funds to provide hotspots through AT&T or Starlink. If they don't have a working tablet, we can provide that for them for the duration of the program. We can overnight or mail medications if they can't get to their pharmacy nearby or their pharmacy is out of those medications. So while I would never want you to promise this to any of your potential patients, I want you to know that we have really tried hard to think about how to address disparities in our state. Um, and we have some funds and some mechanisms to sort of do that. So this is a partnership between WVU and Brown University Health in Rhode Island, one of the Ivy League institutions that has a really storied program for children's mental health. They have the oldest children's mental health hospital in the United States. It's called Bradley Hospital. I think it's like 200 years old or something. It's pretty crazy. And since the pandemic or so, they've pioneered an all virtual partial program. So they were a natural fit to partner with to try to help us learn how to do this and bring it to the state. The program typically lasts 4 to 6 weeks, and because of the Department of Ed's request, the students participants will be made homebound for the duration of the program. So I am happy to write a homebound letter if that has not already been done. I imagine many kids referred to the program are probably already homebound, but they'll be homebound for the program. And I'll tell you a little bit about the school support we'll provide because they'll be homebound. The program lasts from 8:30 to 3 with some potential for some 3 to 5 p.m., family therapy sessions, individual sessions. And the program is broken out into four big tiers. Group therapy is a huge part of the program. A lot of the hours each day are spent in group therapy. Our milieu therapists are initially going to be provided by Brown, and they are top notch. Some of these milieu therapists have worked as milieu therapists for 30 years. So they've seen it all, they've done it all, and watching them do group is really quite an art. And I think any of you who've done group therapy, gosh, it's an art. It's an art to get 12 adolescents in a space to do group therapy. We'll do individual therapy. We'll do family therapy, which is rare in West Virginia, right? We don't have a lot of that here. We kind of do the structural family therapy in this program, given the time constraints. And then medication management through me. That's what I will be doing. And then there's a daily team meeting. So here's a more specific breakout of what we're looking at. There'll be a virtual drop-off in the morning. There'll be a community meeting led by one of the behavioral health specialists. Sort of, if it's a Monday, how was the weekend? And I'm not talking like, oh, what'd you do Saturday? They sit and go through each chunk of the day through the weekend with the kid. And there's a reason for that beyond rapport building, right? We really get to know these kids and families. We really are intimately involved because the whole point of intermediate levels of care is adaptive prosocial community engagement, right? We have to help these kids and families address their concerns where they're at so that they don't worsen and need higher levels of care or so that they improve psychiatrically. So there's a skill group then in the morning, and this can vary widely. I may incorporate Center for Mind Body Medicine, small group, in this. I got training from James Gordon in some of that. Some of this can be, you know, looking at distress tolerance or boundaries or social support. A lot of our program is very transdiagnostic. Again, it's a generalist program. So you'll see us weave in CBT, DBT, IPT, MBT, ABA, right? The whole alphabet soup of interventions will kind of weave into these small groups. From 11 to 12, there'll be a tutoring support program. It's provided by a private company, so a licensed West Virginia teacher, two of them, will be on hand for that hour to help the kids do the homebound homework that they've been assigned. If they're homeschooled, we'll figure out what needs to be done and support them there. It's an hour a day, right? So here's the devil's bargain. This is a partial hospitalization program to make your mental health better so you can go back to school and do good, right? This is not a school-based partial. We had those in Pennsylvania where it was mostly school with a little partial. This is mostly partial with a little school, okay? In the afternoon, we pivot to another group activity and then make sure we do some checkout time, crisis planning, safety planning each day, that sort of thing. So, roughly speaking, referrals will come from a variety of places. They can come from the emergency room, they can come from a consult liaison service, they can come from an outpatient clinic or an outpatient provider of any ilk. They can come from an inpatient unit, they can come from a residential treatment facility. Our director, Lauren Lasnik, will sort of review the initial referral. We have internal referral orders at WVU. We have external referral paperwork. It's real simple. It's not too complicated. And we'll kind of, Lauren will kind of look at it and say, okay, if everything sort of checks out, there's no obvious, this is just not going to work. We'll schedule them for a Connect appointment. We used to call this the Access Clinic. This is the Connect Clinic. Dr. Laura, I see Dr. Newhouse on here. I'm trying to rope her into this nonsense too. Um, we'll hopefully see the patient for an intake, especially if they're external to our system, right? Not that we don't trust any of the providers outside of our system, but we would love that additional data point of like, hey, what's going on? What are we seeing? Is this the appropriate level of service for them? Is there medical necessity for them? Proving that all sort of passes muster, then myself and the Brown team will review the referral, and Lauren will call the family, make sure everyone understands the technological needs and make sure we've addressed that. Make sure, you got to log in 5 days a week for like 6 hours a day. You ready to do that? I know in some of your experience in West Virginia, the guardians or the parents may sort of take the view that this is the kid's problem, right? Like this is the kid's problem to fix. And we're very much family oriented, right? Like this is a family problem. We're all going to work on this together, and it's not just the kid. And I think that's a really important paradigm in children's mental health. Lauren will help make the kid homebound by contacting the local district and getting that paperwork filled out. The Department of Ed has reassured me that this will only take a week, that this will not be a hindrance to them starting the program. Um, and then the program can start. At first, I don't know how long all of this will take. There's going to be
Well,
kinks we have to work out. Oh, go ahead. Is someone talking?
yes,
Oh, please go ahead.
I think you're okay.
Oh, okay. Um, so the the hope is this takes 2 weeks. Once we're up and running from referral to starting, my hope is 2 weeks. But the important thing to point out is that this is not a safety plan. So if a kid is being really unsafe, is really struggling with that, inpatient and residential treatment facilities are still appropriate levels of care, right? So we have to sort of, that's part of this referral process, is making sure that they can be in the community with the current symptom load. Um, I'm trying to sort of partition the 12 spots a month to sort of save a little for the emergency room so that people don't have to board as much waiting for services they may not actually need. Maybe this is more appropriate. Stepping down from an inpatient unit, we have 4 in the state, right? That's like 60 some beds or more. So, I don't know that I have enough spots for everybody, but I'm trying to sort of have a rational approach to where if you're an outpatient provider, that's treated as just as important as someone stepping down from an inpatient unit, right? Like I want to try to serve all the buckets that may be coming in, although 12 kids for the state of West Virginia is surely not enough, right? 12 kids a month. That's I have a hard time believing that's going to be enough. So we'll probably need more teams at some point. Um, I will be available to the provider, whoever referred the pediatrician, the therapist, the psychiatrist, for 2 months after the program to talk directly with them, not with the patient, but directly with the provider to provide any support. Hey, you guys talked a lot about needing to do some of this ABA stuff. We haven't found ABA services. Do you have any suggestions in the interim? Prozac's at 40. they're having a recurrence of depressive symptoms. Do you think I should go to 60? Those are conversations that we can have after the program. And our intention by doing this is to show that this is not a fly-by-night situation, right? We're interested in the success of the patient in their community and want to do our best to support that. We've also had great conversations with Aetna, case managers at Peak, case managers at Blue Cross, to sort of coordinate how to help disposition, how to help referral, right? Each one of these entities has some kind of sense of who's really utilizing a lot of ER visits, right? And really struggling to make headway. So we want to look at those as a referral source and look at those as a disposition support. And like I said before, sort of answering the JCAPS call, we want to do an outcomes research study that looks at a wide variety of measures as to, okay, how efficacious is this program and in what way, right? So kids feel less suicidal, kids are getting a job, they're re-engaging in their religious communities. How can we think outside the box to sort of think about how do we help kids return to their best selves uh, in the community? So just a few scenarios, if to make this maybe a little less abstract. Um, and I made these up, so you'll have to forgive me. So a 15-year-old from Pocahontas County was referred from the emergency room after an episode of self-harm in the context of experiencing worse suicidal ideation and depression from bullying at school. So they're referred to the partial. Grandma stays with the kid to help because mom, has to work in the day. Parents are divorced, dad's an over-the-road trucker, so he's able to join the virtual sessions for the family therapy no matter where he is. And, grandma can also because she's sort of a caregiver in the mix. And despite living in rural West Virginia with multiple caregivers, this kid's able to receive intensive outpatient services, hefty doses of therapy, hefty doses of, medication management. So this is in practice how someone who would be, unable to access these sorts of services could do so and remain in the community. Let's talk about Josh, 17-year-old in Morgantown, anxiety, school avoidance. You don't have to have the diagnosis nailed down to refer to the partial. It could just be school avoidance, and no one's really quite sure why. And in this scenario, the high school, sort of referred because this kid is truant and, facing judicial action over that and, not the good student they were. So we work with the school. The kid does the program from school because school avoidance is the problem, right? So helping them do the program from school, two birds, one stone. Um, Mom works for WV Medicine, so she's joining the sessions between work, and dad's home when he's doing the program. So this care coordination reduces school avoidance, improves attendance, and really addresses the underlying issue. One of the things I didn't mention in a previous slide is we'll have 2 half-day return to schools. So the kid can go back to the school program, to the school, we'll see how it goes, and then they come back to the program, and then we troubleshoot. So, I think that that's really a shining part of the program is it's not just school reintroduction, but that can be sort of a surrogate marker for so many things, right? And helping them get back to school and be successful in some cases can be really helpful. And then here's a Putnam County example of 14-year-old in foster care, having self-harm concerns, having mood instability, sees a therapist and a community psychiatrist, but just we're not making the progress we want to see. So we do the family work. They're able to access the program from home, and we're able to support a foster family and sort of making whatever placement situation they're in more successful by addressing her underlying mental health needs. So
Dr.
fundamentally, please.
Sorry. There's some stuff put in the chat. So
Yeah.
Lauren had said that I think it would be helpful to get you connected with the Mon County Schools um, Department of Human Services as well about truancy referrals if you are open to this. I think they would also be a great referral for you. Please let me know if
Yes,
I can
I
help.
think that's such a great point. Yeah, we've been working with Angela Hayes at Mon County, but I think you're right, Dr. Swiger. I think that that is going to be a huge piece. The only thing I wonder with the truancy referral is not all truancy is mental health related, right? And where that line is, I think we're going to have to sort of live in the real world with it. But I love that, and I think that's
Well,
great. And I
you
welcome
could
any help.
also offer to assess for that because right now they do not get an assessment. It is assumed that it is, and they get ordered to residential for truancy without the assessment. So that may also be a unique pathway for whether it is PHP or other needs, because right now a lot of truancy cases go right to placement without the assessment piece. So I don't know if that would be helpful, but I think that could be
I would
excellent.
love that. I would love that. Thank you. Yeah, no, yeah, right. Like only the only way you could decide you don't like school is because you have a mental health problem, right? Like that's a little silly.
That is the assumption of
Yeah, yeah,
the judicial system.
yeah. I think that, in West Virginia, we've had situations where judges have ordered very specific treatment. I saw a case where a judge ordered specific ultrasound treatment for autism. Um, I saw cases Dr. Swagger talking about, right, where, okay, this kid needs to go to RTF and that's the treatment disposition for them. And so I think I'm very interested in working with the judicial system to sort of what this slide says, right? The right care at the right time at the right place. If we need to send a kid to Alabama because they need residential treatment, fair enough. If that's what actually needs to happen, right? That's, I think, the question on all of our minds is this what really needs to happen? So, together we're looking to improve coordination and care, reduce emergency room visits and inpatient admissions by getting people the care they need in the community. And that's one thing I think I'm very proud of with the partial is this is real life, right? They're in their home, they're in their school. We're going to try to help there because that's where they are or should be most of the time, right? And so I think that I love that part of the model or the paradigm is that like, hey, how can we help in sort of the place that they live? All right. What other questions or comments does anyone want to have?